Uh, Dear Chairman, it's a pleasure to be invited to present a DBC 21. And the title of my presentation is Intravascular Imaging for Unprotected Left Main Stem PCI, a survival analysis of 11,264 cases from the BCIS National PCI database. My name is Tim KINNAIRD. I'm presented on behalf of my authors. So the background to this work is that there are relatively limited registry data that support the use of imaging to support unprotected left main stem PCI. And in general, these data are consistent in that a reduction in mortality is observed associated with imaging use. So we used the BCIS National PCI database to explore this question in more detail, exploring temporal changes in the use of imaging for unprotected left main stem PCI. We defined the associates of imaging use and correlated clinical outcomes with imaging use. Here's the patient flow. So in total, between 2007 and 2014, we had almost 700,000 procedures. Obviously, we only included patients in whom left main stem PCI was undertaken. We excluded shock, we excluded protected left main stem PCI, and therefore we're left with 11,264 unprotected left main stem PCI procedures. In terms of imaging use to support these procedures, you can see that the use of imaging increased from 30% in 2007 up to around 50% in 2014, which is the most contemporary study year. But even in the most contemporary audit data presented, imaging is still disappointingly only used in around 50% of unprotected left main stem PCI. As one might expect, the majority of imaging modality used was IVUS, although in latter study years, in the gray bars, you can see an emergence of OCT compared to IVUS in the blue. So we analyzed all the procedures as I've outlined between 2007 and 14. We used multivariate logistic regression to identify the associates of imaging use. We then propensity matched to create 5,056 pairs of subjects with and without imaging, and used logistic regression to quantify the association between use of imaging and clinical outcomes. Additionally, we used multivariate logistic regression to identify the independent predictors of 12-month mortality. So these are the independent associates of imaging use during unprotected left main stem PCI. So radial access was the most strongly associated factor with imaging use, bifurcation disease of the left main stem, and stable angina presentation. Interestingly, also a teaching case where a trainee was the first operator was also associated with increased use of imaging. Some patient comorbidity, including low ejection fraction and increased baseline disease, were associated with the reduced use of imaging. And this has been observed in other registries of imaging use where increased comorbidity is associated with less frequent imaging use. Looking at the clinical outcomes, so any coronary complication, the occurrence of this was reduced by around 22% when imaging was used compared to no imaging. In-hospital death and in-hospital MACE were also significantly less frequent in association with imaging use. However, mortality at 30 days and at 12 months was associated, was improved when imaging was used and was 34% less likely at 12 months when imaging was used. I think an interesting observation here is that the factors that perhaps one would perhaps not expect to be improved with imaging use, such as acute kidney failure and in-hospital major bleeding, were indeed no different regardless of imaging status. And I think this is reassuring, and these data would imply that the modeling used to correct for differences between the two cohorts was robust in adjusting for the comorbidity. There's a Kaplan-Meier of survival out to 12 months by imaging use in the blue where imaging was used, and in the orange, where no imaging was used. And you can see there's an early separation of the mortality curves, and they continue to diverge out to 12 months. Here's an interesting forest plot of some important subgroups. Here's the overall reduction up here of 34%. But you can see as operator volume increases from quartile 1, 2, 3, and 4, that there's a statistically significant interaction, i.e. that the higher the operator volume quartile, the greater the benefit associated with imaging use versus no imaging use. And I can perhaps expand on this a little. We have a paper also published looking at operator volume and unprotected left main stem PCI, and higher volume operators are likely to take on more complex cases in general. And so these data would imply that the more complex the case, the greater the benefit of imaging. No statistical interaction whether the patients present with an ACS or with stable angina, no interaction between low and normal ejection fraction. But again, here a signal for complexity whether LED was involved, there is statistically significant interaction when imaging was used compared to when imaging was used without LED interaction. And finally, the multivariate associates with survival after unprotected left main stem PCI. Of course, there were the usual candidates such as renal failure, age, and low ejection fraction. But here you can see the imaging is statistically independently associated with a reduction at 30 days and at 12 months survival. And looking at the totality of the data, here are the 4 studies previously published. Here's an analysis from SCAR, an analysis from Spain by Hernandez et al., and 2 Korean studies from Gao et al. And Park et al. And generally, these studies show around a 40% reduction in 12-month mortality when imaging was used to support left main stem PCI. And our data is very much consistent with that, implying at least a consistency throughout the data on a registry basis. So to conclude, imaging used to guide unprotected left main stem PCI increased year on year during the study, but even in the most contemporary years is still only used in around 50% of cases. Use of imaging to guide left main stem PCI was observed to be associated with significant improvements in 12-month mortality, and greater improvements in survival were observed with more complex left main stem anatomy and in higher operator procedural volumes. And the major limitation of these data, of course, is that they are observational and therefore subject to a bias introduced by unmeasured confounders. But these data do highlight the need for a large survival randomized controlled trial of imaging used to guide unprotected left main stem PCI. Thank you very much.